Hi, my name is Brett Jenks. I'm the President and CEO of RARE. And I've been thinking a lot lately about how to improve the performance of conservation as a field. So today I'm meeting with and interviewing to share with you Dr. Donald Berwick. Don runs the Institute for Healthcare Improvement, and he's just recently been tapped by President Obama to take on the challenge of improving the quality of Medicare and Medicaid, a big challenge. But over the past 20 years in healthcare, he's been sort of a leading experimenter. He's put a premium on testing, on measuring, on adaptively managing practices so that doctors can improve the way they provide patient care, so that hospitals can improve the protocols in the emergency room. He's had a big impact. He's partnered with donors to encourage hospital administrators to take on the similar challenges, identify problems that they want to solve together, and then work together to collect the data, analyze it, improve, and then disseminate that learning. And so I'm going to ask him a few questions, and hopefully we'll all learn something from the process. Thanks.
Well, there's more than one reason why it's hard to improve healthcare. The biggest one of all, I think, is fragmentation. The healthcare industry developed in silos, and so patients need a continuous experience no matter where they are as they journey through their illness. But that's not the way we built care. We built it in pieces, and the whole system is erected to support those pieces in finance and supervision and training and disciplinary boundaries. We just suffer from boundaries and walls where we don't need them. I think a second is a lack of optimism. People in any industry start to believe that they're doing as well as they can, and the reason is that they're trying as hard as they can, and they lose the notion easily that they can find a better way to do the work, that there's a different way to do things that will produce much better results. And without optimism, you really can't make progress. I think a third is resources. It's not just money, it's time. You know, you can't improve. All improvement is learning, and nobody can learn without an investment in learning. So if you want to improve the outcomes in healthcare, you have to invest time and energy to learn, study, find better ways. Our mantra is this: every system is perfectly designed to achieve exactly the results it gets. So if you want to improve, you have to have a different system. You have to do work differently. How do you do that? You can do it by finding someone else that does it better than you, studying what they do and importing that knowledge. You can do it by investing in small-scale, local research and development, trying different ways to do things. And you can do it by collaboration. Get together, those of you who share a problem in common, and begin to explore together, and you can learn. See, it's an attitude shift in which you acquire the notion you want to do better, you understand that systems are at the heart of it, and then you look for better systems. It sounds simple. It's actually pretty hard. What we do is work with hospitals or clinics or physicians or health systems with disciplined measurement, charting results over time, and then trying changes as we go and watching the characteristics of the organization or the physician or the hospital change over time. Most of what one knows how to do in life, most of the learning we do isn't done through formal experimentation. It's done through the dynamic and very disciplined process of iterative learning. That's what improvement looks like. Just like a child getting on a bike. They're not doing formal experiments, but they're trying things and studying the results of what they do. In the world of improvement, we call this PDSA, plan, do, study, act. It's a cycle. Plan an improvement, find a better way, try it out, and assess the results of what you did over and over and over again. It's the learning process. Frankly, the incentives that I rely on most, the ones I really trust, aren't extrinsic, they're intrinsic. Most people want to do well. They really want to see healthcare relieve suffering. They have a sense of that. Not all, but many. And that's what you have to appeal to in the end. You have to get people by the heart. And with boards of trustees, that can happen. You can ask questions like, why are you here? Why do we exist? What adds meaning to your life? What would you regard as real success in the long run? when you're old and look back, what do you want to have contributed to this hospital or this community? And I think if you can begin to engage, that helps. The best donors are the ones who say, improvement is so crucial, we have to take the risk to learn, and we're going to help you do that. With the Robert Wood Johnson Foundation, we tried something very risky 10 years ago or so. In automobile manufacturing, there had been a study called The Future of the Automobile, which searched the world for best practices in automobile production. We said, you know, we could do that in healthcare too. There is no perfect hospital, but we could try to make one by patching together the best we can find in hospitals all over the world. So with them, we worked out a project called Pursuing Perfection. Even the name sounded crazy. But we searched America for hospitals willing to join in. There was actually a competition. 7 systems were picked. And for 5 years, they worked together pursuing perfection. Now, nobody got there, but the amount of learning and you know, the outpouring of better measurements, better models, better ideas, great leaders, great teachers was incredible. I think it made a profound difference, and that's because that foundation was willing to take a risk on something so bold. And that's where the donor counts. I would have focused on results from the start. I would have made sure that we decided what improvements we were going to go after and measured those. The other change I would have made is an earlier linkage to finance. There's this kind of belief that somehow there's money and then there's quality. Well, there really isn't. That quality itself is a matter of efficiency and smoothness and the avoidance of waste. We don't have money to waste in healthcare. I'm sure you don't in the conservation world. And so these ideas of getting the financial perspective and the experiential perspective together in one screen, that would have been really important. These were just lessons we learned. And there are always people that want to get going. I bet we can do better. and what I try to do with my colleagues, we find them. We find our friends. We find the people with the sparkle in their eye and the fire in their belly, and then we get going with them. Over time, results accumulate, and some of the more skeptical people become more interested. And it's a kind of developing wave. Get the early adopters, work with them, and then the rest will come. Change agents are lonely. There may be only a few, even in a large organization. But if you get together and you discover each other and you say, what do you know that I don't know, and how could I learn? Then you start to generate energy for yourself, and then that can translate into energy for others. So to people in conservation who are discouraged but think things could be better, my message would be, get together. Don't get discouraged. Find the energy in each other, in the collaboration. Your purpose is noble, and you have a right to get together and pursue it, even if many of the signals you're getting right now is that it can't be done. It always starts in the middle. I mean, so your board of trustees, your executive is non-board. It's always that way. It's always that way. They're skeptics. They got a lot to do. You start and generate the energy, find the optimism, build the cadre, and then take the message. Then the governors and the executives have the job of getting to know what you're doing and see if they can build on it. Don't give up.